Madam Administrator, are you all set?
We are all set, Madam Chair. We're on YouTube Live.
All right. Good afternoon, everyone. I'm Representative Kathy Abercrombie, the Co-Subcommittee Chair for the DSS Work Group. I want to welcome you all here today. We have a lot to get to, and we only have an hour. So my thought was, if it's okay with all the legislators, what we would do is, instead of having the commissioner respond to each question, we would go through each question and then let legislators ask any follow-up questions. Is that okay with the committee? Mm-hmm. Seeing no one saying no, that's how we'll proceed. So question number one, the status of the expenditures of the GF, CF, ARPA fund allocations for the 22-23 biennium. Any questions on this question? Can't raise your hand for some reason, because we know sometimes our computers are funky. Just shake, just wave, I mean, just shake, rattle, and roll. All right, seeing no questions.
Oh, wait. Sorry. I just wanted to, I'm trying to find my ARPA list.
I have it. I have a number of them.
I got it. There are a number of entries that we've got on there that were not distributed, and I wanted to know. One was the $1 million for the funds for the nursing home workforce development. The other $750 for Mary Wade Home, the nursing home family support 10 million, the funds to certain entities, the funds to Fairhaven Clinic 10 million, and the funds for community action agencies 5 million, and then there's another one for New Reach Life Haven 500, and one other for 2.5 million for My CT resident one stop.
Representative, are you looking for response to those?
Yes, I'm sorry. Yes, I am. I just like to know, where are they? And if you don't, we got this list from from OPM as to these were the allocations that we did last budget year, and none of them have been settled yet in any of the documentation. So we would like to know where these funds are in DSS, because they had been identified as DSS items.
Commissioner Gifford, if you're okay, I can jump into a few of those.
Yes, thank you, Kathy. So Representative, I just will, while Kathy's talking, I'll refer you to Appendix 1. Do you all have the document that we prepared for this work session?
Appendix 1.
I apologize, my document doesn't have page numbers, but it's about.
It's towards the end of our packet, colleagues, if you had printed off the whole 30-page packet.
It's not in the it's in the middle, it's in the very middle, because it's Appendix 1. Okay, I see that. I did not.
And it has an implementation status column.
Correct.
For each one of the items.
Okay.
So go ahead, Kath.
No, absolutely. I was going to refer you to that. It does give you the updates. Some of the things, some of the dollars that were allocated to DSS have subsequently moved over to another state agency, a more appropriate state agency for the actual contracting. For instance, the New Reach Life Haven shelter, they already have an established relationship with the Department of Housing. We entered into an MOA. They have the funds over at Housing, and they're working with New Life Shelter. Workforce Development, Education, and Training. Those funds are going to the Office of Workforce Strategy so that they could utilize them. And then the Fairhaven Clinic, the $10 million, which was for improvements to the facility, that has been transferred over to the Department of Mental Health and Addiction Services, who does the central contracting unit, and they are working with Fairhaven.
Okay. I was just informed by Madam Administrator, and I apologize, that we have a meeting with Commissioner Gifford to talk about this on another another, so I won't take up the time to go through. I do apologize because I don't know all the meetings, and when I saw Commissioner Gifford, I said, oh, well, let me ask her about ARPA, but I guess we had scheduled. So I sincerely apologize, but I will ask about just one item on here. And it's the community health workers for Community Action Agency. I know we're in the process of trying to work that out, but it dawned on me when I started looking at it that we're paying $30,000 a person and paying them $30,000 for a full-time job. If I'm not mistaken, it is a full-time job, correct? It would be a full-time job?
Well, that would be at the discretion of the community action agencies representative, how much they wanted to hire them for. I believe the original intent did specify $30,000 per community health worker in last year's bill.
So they have the ability to pay them more than $30,000? Kathy, Commissioner?
Go ahead, Kath.
So as Commissioner Gifford stated, the legislation did limit it to $30,000 per community health worker.
Mm-hmm.
So whether or not that's a full-time or part-time, I guess would be at the discretion of the Community Action Agency. As you know, we haven't gotten that far yet because that's being fixed.
Mm-hmm.
Money that we were able to, that was allocated, the 270 was $30,000 per CAA. The CAAs are putting together an application and will respond to that. But the larger pot would be a cap of $30,000 per community health worker. Whether or not that means a full-time or part-time would be up to the CAA.
Okay, I look forward to us ironing this out very soon, very soon. But I will say that, I mean, we do too many things, but when you look at $30,000 for a full-time worker, that's less than minimum wage. And we do not condone anything that pays anybody less than minimum wage. So I just want to make sure that as we go forward with what we're going to do with Community Action Agency, we are not holding to paying anybody at that small amount, because we're pushing them on Husky and we worry about that, and we're a variety of things. I don't need you to go into them. So I just wanted to bring that to everybody's attention. And I look forward to our conversation about that as we talk about the MOU and how we're going to get that started. Thank you. Thank you. Thank you, Madam
Thank you, Representative Walker. I am going to ask members to keep their questions short. We only have 1 hour. Representative Dathan?
Just wanted to double check that. Are we asking questions about I was a minute late joining. Are we asking questions just about the responses, or if I have follow-on questions, can I ask them now?
No, we really have to get through the responses, and we
Okay.
have 30 pages. So
Yeah, I'll hold on to my questions then.
If
Yeah,
there's time at the end, we can do follow-up, but we really need to get through this.
if not, I'll share them with the administrator. Thank you
That's
very
fine.
much, Madam Chair.
Yep, that's fine. Thank you, Representative. Any further questions on item number 1 about the ARPA dollars? Seeing none, we will move on to item 2. Please identify major providers groups who have not received a rate increase in recent years. Any questions on this particular area? Because there's a lot here.
Shed some light on it, and we can certainly follow up after this.
I have one question relative to United Services.
Mhm.
United Services in Northeast Connecticut and Generations down in Willimantic. Both of them cover not just standard and services, have a combination of services. I think, Commissioner, you've talked before about looking at people doing sort of combined services, and that's what United Services is doing. So we, in our neck of the woods, are being told regularly by United Services that they receive less money than other groups that do similar things, and they do DV, they do domestic violence, they do they find supportive housing, They do make sure that people get their medications right there so that they don't have to go anyplace else. They do counseling. They respond 24/7 to those in crisis. So I'm curious. I've never been able to figure out why their rates are so much lower than the rest of the state.
Senator, I think the most fruitful way to get to the bottom of this would be if there were specific examples of places where they feel they are being compensated differently. As we noted in our response for the behavioral health services, there is a standard fee schedule for that. So to the extent they bill Husky for behavioral health services, that they get paid the same as everybody else for the same service. Some of the other services you described, such as domestic violence, that might come through different funding sources. I can't speak in detail to how those are all allocated to that particular provider, but we'd be happy to hear their concerns and offer any explanation we can.
Thank you. I've sent the documentation several different times on this particular group. I know Representative Walker and I have been talking about Fairhaven and their rates also. So we seem to see that there may be historical rates by some groups and not necessarily rate increases. So I will resend the United Services issues over to you. Thank you for that. Thank you, Madam Chair.
And if I could just add on Appendix 4, which is, I want to say thanks to the team and to OPM for helping us recreate this historical document that goes back to 2008 on all the different provider types. I did just want to make a couple of notations there. First of all, is you'll see a chart and then some added notes at the bottom about obstetrician rates. It's noted in the chart that there was a reduction. I don't think what's noted is that obstetricians are paid for historical reasons in Connecticut that predate me at a rate higher as a percentage of Medicare than all of our other providers. So although you'll see a reduction there for obstetricians, they continue to receive a rate that's in excess of the Medicare rate. The PCP rates are a similar example. You'll see a notation about a reduction in PCP rates, but you all might recall that with the passage of the ACA, Medicaid received full reimbursement to provide 100% of Medicare rates to primary care providers. That's since been reduced to something slightly less than 100%, but it's still greater than the percentage of Medicare paid to our other physician providers. So there's a little more nuance than just what you see on the chart, and we'd be happy to sit down with you and walk through it a little bit more. It's obviously a complicated topic, and we're happy to discuss further.
Commissioner, I've sent that document over to you.
Thank you, Senator Austin.
And if we could, as we're making explanations, if we could use the full definitions versus the acronyms, so PCPs, primary care providers, just for everybody. No problem. I know we're used to using it that way, so thank you. Representative Dillon?
Thank you very much, Madam Chair, and thank you, Commissioner. I guess I'm concerned. I share the concern about Fairhaven Clinic, and I know that there were some decisions that preceded you that seemed to be, frankly, arbitrary, and there were some reductions that were made that were frankly arbitrary before you were there, not by you. And I guess following up from here, and we don't need to chat, like I worry about like radiologists, and I worry about Fairhaven Clinic. There's a whole list we've got in our heads of trying to make sure that nobody gets lost. And even if some providers got increases, some of them may be lower than they were, let's say 6 years ago, when there were very arbitrary cuts to some rates. And I just wanted to leave that there. And it's not an accusation of you at all. I just want to make sure that that people have access to care and that we're able to keep providers in the system. Thank you very much, Madam Chair.
Thank you, Representative Dillon. Representative Johnson.
Thank you so much, Madam Chair, and thank you, Commissioner. I just wanted to follow up on your remark with respect to Medicare and obstetrics. If someone's going to have a baby in that circumstance, they're probably in disability because you wouldn't get Medicare coverage otherwise. So that may be one of the reasons that the amount is higher.
Not necessarily, Representative, because Medicare, they have a rate for that service.
Yeah.
I don't disagree with you at all that it's not a highly utilized service in the Medicare program for obvious reasons.
Right.
But there are a fair number of young women in the Medicare program. And so that's just a benchmark. It doesn't really relate to the clinical conditions. It's really just a benchmark of payment. And I just wanted to make sure that committee knew that our rates in that particular area are fairly generous compared to others.
Well, I guess we need that since everything's being shut down, but I won't digress. So thank you so much for that. Thank you, Madam Chair.
Thank you, Representative. Any further questions or comments? Seeing none, we'll move on to item number 3, residential care facilities. So I think under the residential care homes, we are going to have to put some dollars in the budget to help them because we know that we are not going to be prepared for the reimbursement with Medicaid anytime soon. So I just want to kind of red flag that for the agency. I know that I speak for my co-chair, Senator Kushner, when I say that we would love to work with you on this and find out realize what's an acceptable rate to give them. But I think we really need to do something in this budget. Any further questions or comments from colleagues? Seeing none. Moving on to item number 4, nursing home rate increases for FY20 by funding source. If you look at Appendix 5, gives you all of the dollars that the nursing homes have received since 2020. Does anyone have any follow-up questions on that sheet? Seeing none. I just want to make sure I'm not seeing a hand raised. Moving on to item, oh, sorry, that was 4. Item 5, how much has DSS spent on COVID tests and what is the per unit cost? Any questions on this particular item? Seeing none, moving on to item number 6. I think this will be open to a lot of discussions. Caseload trends. Please provide cost and caseload trends used for the current service adjustments, particular TFA, Saga, and Husky B. Any questions on this particular slide? Senator Austin.
Thank you for that. And I have been concerned about the TANF and Saga decrease in caseloads, mostly because I'm really curious on whether or not the caseload reduction is relative to the policies surrounding TANF and Saga and not having anything to do with the fact that we have less people applying. They're not applying because it doesn't allow certain aspects of the program to continue, and it's making it very difficult. So I'm curious, what is your opinion on why there are less TANF and Saga people applying for either of these programs?
Senator, I don't think we have a definitive answer to that question, which I appreciate is less than satisfying response. Most likely it's a combination of factors. I believe you are correct, and I'm going to turn to Peter Hadler, but I believe you are correct in that application activity, at least for TFA, has remained fairly steady. I can't speak to Saga, but Pete, do you want to amplify or add anything for the senator?
Yeah, I think that we have obviously been fully aware of this enrollment decrease. We've been watching it happen for several years here and trying to get a good understanding on the root causes. There is still interest. We do receive a fairly steady flow of applications requesting cash assistance. Increasingly, though, we're unable to find people eligible. And I think that some of that has to do with longstanding eligibility policies and rules that have sort of made the door to entry smaller over time. We've suppressed cost of living adjustments, and the threshold for eligibility has remained extremely low over time. These have historically always served some of the poorest residents in the state, but you increasingly need to be comparatively poorer over time when the eligibility threshold stays still and there is inflation and cost of living adjustments over time. So we do think that is a driving factor in that.
Thank you for that. I'm curious why the agency hasn't looked at this continued decrease and made suggestions relative to inflation and cost of living increases that would help out those that are really the poorest people. And it's not like we're overly generous. We're giving people, in the case in 2018, $201.21. And if we're looking at 21, we're at $203.33 when we've had significant inflation and significant cost of living. So I guess what I'm looking for is for you to supply us with what your recommendations would be to address this issue, because we can't continue to go down like this and not provide the resources for some people that their choice is this or, and in some cases, some of the people receiving this are living on the streets too. So what are we doing? I'm sorry, I needed to grab a drink. So what can we do to address this issue and make it a fairer program, a program that actually provides access for these people that are really the poorest of the poor? That we don't put hardly any money in this, relatively speaking. We are at 19 million and now we're projected to be at 12, almost 13 million. So, it seems to me that we could leave it at 19 million and make some adjustments and provide more resources for people.
Senator, we'd be happy to provide you with some recommendations. I would note that we have taken a number of actions in partnership with you all on the program. I articulated a number of them yesterday with respect to facilitating the application process in our human services hearing. We did eliminate the child cap. I believe we successfully did that during the last session, which was a big adjustment. And then, of course, the lien, we continue to work on the lien issue on real property liens for people not in the cash programs at this moment, but in other of our poverty reduction programs. So, but happy to continue to talk to you about further.
So if we could get some recommendations, sometime in the next 3 or 4 or 5 days so that we could work on it in the budget. Seems to me to make a lot of sense for us to take this issue on, in particular in this legislative session. Thank you very much.
Senator Austin, can I comment on that if it is possible?
Representative, raise your hand. There's colleagues that are above you.
I'm trying, but it's not working for whatever reason.
So one moment, please. Let me go to our other colleagues first, and then I'd be more than happy to go to you. Senator Austin, just so you know, we have some bills in human services addressing some of these issues. Senator Kushner.
Thank you. And my question goes to the Husky B portion that is listed here under this item. And I don't know if, I concur with Senator Austin's comments on Saga and TANF and all those above, but I wanted to also ask, I remember the discussion from last year about Husky B and extending that to immigrants, undocumented children, and we were concerned about the cost, and we did cap it at age 8 because of cost concerns. And now we find that based on enrollment, we have a very significant dollar amount that we are going to be not utilizing because of lower enrollment than anticipated. And it would seem to me that we ought to really focus on using those dollars that we had originally planned on toward increasing the age so that more kids have opportunities. We have heard from many immigrant workers in our public hearings already this year that there's a huge number of people who don't have coverage for their children. And I think this is something we could really utilize, it, including with the idea, I see that also there's under enrollment and major adjustments in the other portions of Husky B. And I would hope we would take those dollars and utilize them effectively to expand coverage, healthcare coverage for as many people as we can in the state. So it's a comment and similar to what Senator Austin asked regarding your recommendations. I think it would be helpful if we knew where the agency stood on that.
Yeah, Senator, absolutely. I would just, if I could, offer to clarify that per the budget, the new benefit for undocumented children up through age 8 does not begin until January 1st of 2023. But it was budgeted for a longer period of time in the biennial budget. So the adjustment doesn't reflect a lack of enrollment. It reflects an appropriate level of budget for that particular benefit, because it was never intended to be implemented before January 1 of 23. So, but it was budgeted for the full biennium. And Nick will correct me if I say something wrong. That's the purpose for the adjustment. So we haven't begun enrolling children, is what I just wanted to make clear.
I appreciate that. It's very helpful to know that, and I apologize for my lack of understanding in this area, which I think is, well, I want to apologize for that. It's the new area for me, but I do think that to what extent we have dollars available, they should be utilized to expand healthcare opportunities for folks. And I would encourage us all to think of what's the best way to do that, including, I've always been concerned about that age 8 in any case. Thank you.
Thank you, Senator. Representative Dillon?
Thank you, Madam Chair. And Commissioner or Mr. Hadler, circling back to the drop in enrollment, I wonder if you could follow up with us, and it shouldn't be hard, on whether or not there's any variation from one region or one town to another on drops in enrollment. I remember with the SAGA program, a governor years ago tried to eliminate it altogether, and we ended up really kind of crunching up all the numbers. And the town with the largest number of SAGA at that time, and I know our programs have changed since then, was Hartford. And the second was, I think, New Haven. But on a per capita basis, the town that was in the top 5 being affected was Willimantic. So it was a smaller area, but which you wouldn't notice if you were just looking at the raw numbers. So that I want to see whether there are, in terms of the drop off, we may have some program barriers, but maybe there are also some barriers, Madam Chair, that may affect some areas more than others. I really don't know. It's a question. If you could let us know soon. Thank you.
Representative Johnson?
Thank you, Madam Chair. And just a quick remark following up on the TANF and the SAGA issues. With respect to the SAGA, the changes that have occurred since 1996 have been a gradual limiting in terms of who would be eligible for SAGA. So what's happened is the people now are only going to be eligible to collect the $216 or $19 a month. Will be people who are applying for disability, and there used to be when the litigation occurred in 1996 on SAGA, because Governor Rowland did not want to pay what was felt by Bridgeport that they would be able to get compensated for the money that they were handing out to people who were in that circumstance. At that point in time, access to SAGA helped with rent vouchers. It took care of a lot of the things that that it couldn't possibly take care of today at $219 a month. So if you look at how it's distributed, I think each town distributes the Saga money in a different way. At least that's been my take on. I've talked to homeless people around in my district and in other people's districts. So I think that how it's distributed, the fact that it's that low, and the fact that it's been limited to people who are just applying for disability benefits are some of the reasons the Saga program isn't actually functioning as it originally was intended. When they got rid of the port farms, the town aid was the next thing to do. And so here we are now we're doing worse than we used to do in colonial times in this circumstance. So so that's a concern of mine, and also of course, the TANF, because I've said before, I have 3 homeless shelters here and people living on the river. So I would like to be able to create a situation where people can stay housed. So thank you so much for that.
Thank you, Representative Johnson. Thank you for your work on this issue. Representative Gonzalez.
Thank you, Madam Chair, and I'm sorry for
That's
I
No
was trying to
apologies.
raise my hand and the system didn't allow me, but thank you. Thank you. I heard Senator Austin, and that was one of my concerns, because in my community, since the pandemic, DSS are not interviewing people one-on-one. They are not listening to these people, their problems and their concerns. So it's very difficult for them. Some of these people, they don't know how to navigate in the system. And some of these people, they are sending the packet, the application, the renewal application, and they are not getting any response. I did have a conversation yesterday with a lady, a social worker that worked for CCI, and she told me that is going on, that she's been trying to help, especially seniors with that kind of problem. So maybe that's why a lot of people, the numbers are down. Because I remember years ago, it was a huge problem that they found the application under a desk. So right now, it's a lot of people, they are sending the renewal application, and that they're not getting any response. So I think that this is one of the problems. We have the language barriers. A lot of people don't know the language, and if they can see one-on-one, some of the people, is no way, how they're going to be able to get in touch with a social worker. So I believe that that's one of the reasons that the numbers are going down, and we have to do something to fix that problem. Thank you, Madam Chair. Thank you.
Thank you, Representative. We appreciate your advocacy on this issue. Any further questions or comments? Seeing none, moving on to item number 7, average enrollment and cost per case by Husky Group. Any questions or comments? I think that one of the areas we really need to be concerned about and look at is Husky C. I think you're going to see some legislation coming out of Human Services that will be going to Appropriations to kind of address this issue. But if any of my colleagues have any other thoughts, I'd love to hear them at this point.
Let's see, raise my hand.
Representative Johnson?
Yeah, thank you. Yes, I just wanted to talk about the fact that there are a lot of the very severely disabled people are in Husky C, and the personal care attendants are not, can be cut off if the person gets an increase in Social Security. And the system for notifying all that whole process is I think, problematic at this point in time, because it's delegated, or there's a contract with DSS in terms of the payment system that is occurring. So I'd like to be able to review that in more detail at some point in time. I think I'm glad to hear that Human Services Committee has a system that they're thinking of. So that's great. But I think the non-compete part of this thing for the personal care attendants is maybe hampering, which is not a Human Services, but comes under the General Law Committee. So that's but it does get transferred back to Human Services, because they claim that there'll be a fee if they lose their hearing on the change in personal care attendant. So that's my problem, and it's going to take a lot of research to try and come to grips with it.
So Representative, you're talking about the home care providers and the non-compete, the bills in human services. We worked with general law on it, and we're also working with aging and disability. We had a public hearing on it yesterday, so we are addressing that.
Oh, great. Well, thank you so much. I'll go take a peek at the testimony. Thank you.
Okay, sounds good. Any further questions or comments? Seeing none, moving on to item number 8, substance use disorder. This is the Medicaid demonstration waiver 1115. Any further questions or comments on this? I know there's a lot of details, folks. I'm just trying to be efficient to try and get through this. Representative Gilchrist. Jillian?
Yeah, I'm so sorry. I've got like,
That's okay.
you know, didn't want you to hear all the other speakers. So yes, thank you so much, Madam Chair and Commissioner. So it's my understanding that the budget presents the transfer of the services to Medicaid as a benefit to the providers. I guess my question is, the new standards the programs will require, though, involve significant new staffing demands. Can you give an overview of new staffing requirements in the new waiver services?
I'm going to turn right to our subject matter expert who's been leading the charge on our waiver, Bill Halsey, our acting Medicaid director.
Hi, good afternoon. And we'd be happy to send that to you. It's on our DSS website. But so in terms of the residential levels of care, we have published our state standards in collaboration with DEMIS and DCF and Judicial Branch about every single level of care that is covered by the ASAM criteria. So there have been some additions related to nursing standards, some additional supervision by licensed staff, direct clinical work hours have increased slightly under the new ASAM criteria. And we believe that we have established rates to support all of the standards that we have put forward. And I will just also say that per our agreement with CMS on this matter, providers have up to 24 months to comply with our standards and the new ASAM criteria standards. And they will be getting the new rate on day one, and they will have 24 months to comply with those standards. But we'd be happy to provide you the full standard document. It's on our website, but we'd be happy to provide that to you.
Great, thank you so much. And then as a follow-up to that, do these new rates take into account the increase in salaries that's happened in the market in the last 6 to 9 months?
We have really tried to be very responsive to the feedback that we have received from providers. I think in every single rate adjustment that we've made, they have gone up. They have not come down based on feedback from providers. And so we've tried to use the most recent Department of Labor statistics and the most favorable interpretation of that. But we do recognize that for those that need nurses for a particular level of care, they are in high demand and they are expensive, but we again have tried to accommodate that within the rate structure.
Great, thank you so much, Mr. Halsey. Thank you, Commissioner, and thank you, Madam Chair. I'm all set.
You're welcome, Representative Bill. If you could send that information to our Madam Administrator, Sue Keene, so that she could send it out to all members, that would be helpful. And any follow-up information that we ask for, if you could also send that to our Administrator, Susan Keene, that would be helpful.
Madam Chair, would you like the link to our website that has all of the information or just the standards?
I think the link would be helpful, Bill. This way members can look at all of the information instead of having to pick and choose.
Okay, thank you.
Thank you. Item number 9, this has to do with the 1115 waiver that we were just talking about, which agencies take the lead. I think it's self-explanatory. DEMIS will take the lead for the adults. DCF will take the lead for the children's behavioral health. And as we all know, every state has to have a single agency that is the gatekeeper for the Medicaid dollars, and that will be DSS. Any further, I need coffee. Any further questions or comments on this particular issue? Seeing none. Moving on to item number 10, how does the waiver impact Cmhs, which is the Connecticut Mental Health Center? Any questions on this particular write-up? Representative Dillon, are you trying to raise your hand, ma'am? Or no? Yes? Can you want to give me a thumb up? Okay.
I'm looking at the responses. Thank you, Madam.
Oh, okay. All right. I didn't know if you were trying to raise your hand. I apologize. Representative Dathan.
Apologies, going through two Zooms here. Just trying to understand with this waiver, do we have additional staffing demands that are going to increase as a result of increasing this waiver?
Bill, do you want to respond?
Representative Dathan, staffing demands within the provider organizations?
Yes.
Okay, so yes, there are some additional staffing demands for the providers. And what we have tried to do is make sure that the rate that we are paying those providers under this waiver allows them to accommodate those new staff, whether they are licensed staff or non-licensed staff. We believe the new rate will allow them to hire the staff.
Okay. Because I have heard from providers that there is, we all hear it about the workforce shortages. And so there's just some concern that we want to make sure that these providers are getting market rates, market salaries for these. I just want to make sure that these waivers took that into account.
Yes, we tried to take that into account, but we also recognize that they'll all be competing for some of the same people, and it's a tough workforce, but we believe the rates allow them to hire the appropriate staff.
Okay, well, thank you for that. Hopefully when we check in next time, we'll have proof of that through actual results. Thank you so much. Thank you, Madam Chair.
Thank you, Representative. Representative Dillon.
Thank you, Madam Chair. I was trying to get the question about CMHC was my question in the previous meeting with the Department of Social Services. And I'd just like some clarity on the answer that we got here. Connecticut Mental Health Center is an IMD, so that it was presented to us that the IMD exclusion would be addressed in the waiver. And I believe my question was, will that affect only, Connecticut Valley Hospital, or will it also affect CMHC? Are the beds included in that waiver? Thank you.
It's a good question, Representative Dillon. The waiver, the 1115 waiver that we are on the verge of getting approved by CMS any minute now, is only allows Medicaid match for residential substance use disorder treatment, does not apply to mental health.
So which facilities then would be affected? Are there any state operated?
Go ahead, Bill.
Yes, Connecticut Valley Hospital. So Merritt Hall at Connecticut Valley Hospital is a state-operated, DEMIS-operated facility.
Right.
And I also believe Blue Hills which is now a part of CVH. And I also believe Greater Bridgeport Community Mental Health Center has SUD services.
And Madam Chair, just to follow up, I'm trying to remember the waiver discussion, which was not terrifically, was not that developed. It was last summer. are there any private institutions included in that?
The vast majority are private, nonprofit, residential treatment providers.
That's right. That's what I thought. Yeah. Okay. Thank you very much, Madam Chair. And thank you for your.
Thank you, Representative. Any further questions or comments? Seeing none, number 11.
I apologize. I was
Oh,
trying to
I'm
raise my
sorry,
hand.
Senator. I'm sorry. Please
No
proceed.
problem. I just was listening in. I apologize. I'm going back and forth between a couple of Zooms, as I'm sure we all are. But we spoke a little earlier about nonprofits, specifically with mental health. And is that kind of what we're on right now, on line item 10?
Well, this, yes and no, sir. This has to do with the mental health waiver that the agency has applied for, the 1115 waiver. And then, yes, you're right. They were talking about some of the providers and how these dollars will get out. So if you have something around that line, now it would be appropriate to ask.
Okay, excellent. It was just, we were talking earlier about nonprofits, specifically helping with children with mental illness, and in Eastern Connecticut, in the Groton area, there is a nonprofit that provides these services. And in Pawcatuck, which is about 30 minutes away, there is a really large need for children that have some mental health and crisis, just from what's going on now, and obviously everyday issues that were prior to the times we're living in now. And I was speaking to some representatives in that area, as well as a nonprofit that does some really good work out that way. And it seems as if the funding, they're a little short on the funding. So they were talking about the DCF budget for the nonprofits, specifically for grants for clinics that deal with children with mental health illnesses. And we were trying to advocate for some additional funding. I believe the line item budget is like over $16 million. And they were looking for $250,000 to be able to get this off the ground. They already have an area that the town is allowing them to use. It's a school that was closed. And I wasn't sure if now was the time to bring that issue up, or if there may be a better time. I think I tried to give a fast view of what I'm looking to get across, but there's a need for it in an area. I think for a very small amount of money. I think a lot of the legwork has been done first because they're doing it very well and successfully in Groton. And there is just simply no easy way for the people in Pawcatuck to get to Groton. There's no bus line, and there's a really big need for it. So I'll stop rambling, and based upon what you already know about this, you could let me know if I'm going in the right direction.
So Senator, I'm glad I'm not the only one that was confused today. We're actually on DSS. DCF comes on at 2. I thought we were starting with DCF also, and I know being on multiple Zooms. So I think your question is more appropriate for the next meeting that should be starting in about 10 minutes. So hold
Excellent.
it thought, okay?
Thank you so much.
You're welcome, sir. Any other questions on that particular question? So the next question, number 11, had to do with, is there going to be any communications around this waiver with the Behavioral Health Partnership Oversight Committee? As you can see that the agency has been engaging the subcommittee and the providers around this demonstration. Are there any further questions on this particular issue? Representative Dathan.
Just a quick question. Does this group, the Oversight Committee, do they report at all to MAPOC?
Yes, they do. They're one of our subcommittees. So we get a report every month from them where they are. It's actually Jonathan Steinberg's is part of it. And oh God, what is her name? I apologize.
No, it's not my subcommittee, and that's why I was just wanting to make sure that we got that as part of MAPOC, because I haven't. Okay, thank you. I know our meeting on Friday, we'll probably hear more. Thank you.
Yep. Thank you, Representative. Any further questions? Seeing none, item number 12, wanted to know how the 2.9 million in ARPA dollars would be used for domestic violence. As you can see, we have a breakdown of those areas. Any questions on this particular issue? Seeing none, Item number 13, identify specialized infant and toddler mental health providers. I think what we were trying to figure out was the dollars that would be used in this particular area. As you can see, they broke it down to the hospital inpatient, intensive, transitional care, behavioral health, maternity bundle. Any further questions or comments on this particular question? I know there's a lot here, folks, and I apologize that I'm sort of like speed dating, right? Trying to go through it. But if you have questions, please feel free to raise your hand. Item number 14. Does DSS have data regarding the average length of stay of children in hospitals for mental health related treatment? As you can see in the breakout, it breaks down the hospitals, how many beds, and the age groups and the length of time. Any questions, Senator Austin?
Thank you very much. So just looking at the chart itself, we're looking at the chart for Four Winds, which is an out-of-state organization. And I'm curious, they have more beds at Four Winds than we do. That's almost that. I think that's adding everything else up. So why are we not increasing in-state beds and providing these resources for our children here in the state? Why would we want to send? Where is Four Winds? First, I don't even know where it is.
Commissioner?
Yeah, it's just over the border in New York. Bill, you know the name of the town?
I will get that. I want to say Katona, but I'm going to check.
Yeah. So, Senator, we have, and there's a breakdown actually in the answer to 14-A about the increase in beds that have occurred in Connecticut hospitals. And that is a result of our policy change from last summer and the increased rates and add-ons that we've added to our day rate. So we are seeing some more interest in our state facilities in adding these beds.
Yeah. Well, thank you for that, Commissioner, but I'm looking at, again, I'm just doing this in my head, but even adding in all those beds, all of them, added 3 beds, added 2, added 10, added 2, added 8, does not reach all together. Everybody else does not reach the 150 that we have for Four Winds in New York.
We don't use all of those. Those are the total number of beds that Four Winds Hospital has.
All right. How many do we use?
Well, we can get that data for you.
Okay, that would be great.
Senator, I will just add, we would love to see more Connecticut hospitals open more child psych beds, which is why we've been working on that with DCF and DPH and OHS very intensely over the last 8 months or so. We've gotten some. We hope that CCMC will expand to their new unit. But you know, they have made a decision for whatever reason to expand in this fairly limited way, and we hope that they'll continue to do so.
Is it because of pay?
You know, in general, as we worked with them over the last few months around their requests, we received pretty positive feedback on the rate of that Husky is providing. I can't speak to commercial payers. So I think we have substantially addressed their concerns around payment. I think there are workforce issues. And then there are, you know, business decisions that the hospitals make with respect to where they concentrate their resources. So.
Thank you for that, Commissioner. Madam Chair, turning it back over to you.
Senator, any further questions? Seeing none, moving on to item number 15, which is a staffing update. How many vacancies, active recruitment. As you look, we have Appendix 7 that addresses this. Any questions on this particular issue.
Representative, if I could, I just want to make sure the committee understands on that appendix. There's a large number of vacancies and a relatively small number of positions that are currently posted. I want to make sure everyone understands that some of those postings could fill many, many, many of those vacancies. So it's not a one-to-one that for 450 vacant positions, you would have 450 postings. Many of those postings recruit and hire for many more positions, particularly our eligibility staff. So I just want to make sure that that was clear for those that were interested.
What is the average length of time for training for someone that has to do eligibility?
Beth or Peter?
It's a significant period of time.
4 to 6 months.
4 to
would be
6
my
months.
estimate.
Yeah, I think that's important for my colleagues to hear because we know that DSS has done a lot of hiring over the last few months. And even though it doesn't seem like things are getting better within the agency, I think that people have to take into account how long it takes to train someone, which means the person that's training them is doing double duty. So I think that's important for everyone to understand as we go forward. Any other questions on that particular item? Seeing none, moving on to item number 16. This also has to do with how many retirements that are anticipated over the next several months. I think the commissioner responded to that in Appendix 7 and also talked about how some of these workers will be taking on multiple roles. But does anybody have any questions about that particular area? Seeing none, moving on to item number 17, autism waiver slots. The question was, there was a 50 slots that we did in the budget last year. This year, the governor's recommendation, which kudos to him, is 150. Did that include the 50 or was the 150 above the original 50? This says it'll be 200 slots altogether, which is good news for the families. Any questions about this particular item? Seeing none, moving on to number 18, methadone maintenance programs. I'm not exactly sure what the question was around the methadone. Does anybody remember who asked it? And Representative Walker.
Thank you. I asked because this is a very big topic for a lot of us, especially in some of our cities and things, and actually trying to figure out what do we do for methadone and what is our responsibility and who's responsible. And part of it is in looking at the methadone clinics, they have some requirements, and I wanted to know, is DSS part of helping to oversee that these requirements are being fulfilled, such as counseling and other types of issues that they prescribe for the methadone maintenance people in their addressing the addiction issues that they have.
Oh, you want to take that?
Or your staff? Oh, go ahead. Sorry.
To the degree that it is related to our payment regulations, yes, we are involved, but DPH actually licenses the clinics, and then DEMIS also has a role related to chemical maintenance or methadone maintenance clinics. But if our payment regulations, for example, the example that you used, monthly counseling is part of our payment regulation, then yes, that would be part of what we would be looking for in any sort of audit that we do.
Okay, all right. And you do how often do you audit them?
I would have to check on that.
Okay, would you let me, because I talked to DPH. DPH basically certifies the building. And I talked to DEMIS, and DEMIS says that the standards are sort of established by SAMHSA. But what I'm really looking for is who oversees to make sure that the services are being provided, that because I'm sure they're billing, how do we audit that and make sure that that's happening? So if you could just give me a little follow-up on that, I would really appreciate it, because there are a lot of us trying to understand who has the responsibility to make sure that they're getting what they're supposed to do so that we improve the quality of life. So thank you. Thank you, Madam Chief.
You're welcome, Representative. Any further questions or comments? Seeing none, item number 19, TFA reduction and impact on the federal TANF block grant. I think the question was, with the reduction of, with the amount of the utilization going down in this program, does this hurt us with federal funding? According to the response, and I'm just speed reading it, it doesn't look like it hurts our block grants. Correct, Commissioner?
You are correct, and there's detail in the appendix, Representative.
Any further questions or comments on this particular area? Seeing none, moving on to number 20, IMD exclusion and the IMD demo. IMD stands for
Institution for Mental Disease, not our acronym that comes from our federal partners, but it's basically a psychiatric inpatient facility or substance use inpatient facility.
So can you, and I apologize, I'm not sure what the question was around this particular.
Yeah, apparently there was a demonstration, Representative. It's detailed here in our response. There was a previous demonstration in which one of our hospitals participated that did allow Medicaid payment for a psychiatric inpatient facility, as opposed to our upcoming demonstration, which will be for substance use inpatient facilities. That demo has ended. There is no such equivalent opportunity in existence now. And so that's how we responded to the question.
Thank you. Is the representative who asked this question on this Zoom, and do they have any follow-up questions? Seeing none, then we will move on to question number 21. What are we doing to increase access to long-term services and supports? There are two websites that are attached to this. I'm not sure if my colleagues had the opportunity to kind of take a look at that and if they have any follow-up questions on that. I think that DSS, do you want to just kind of in a short term, just talk about some of the services that we offer for long-term care, long-term care and some of the services that we offer to help individuals?
Who on the team wants to take that one? That's
that
a long
question because she's the expert.
Sure. Well, Jen and I think can jump in and share this one. So DSS in particular offers a range of home and community-based services all the way from birth through the end of life. And those services address various levels of need depending upon where the member is. They all reflect the values of a dignified delivery of service, of person-centeredness, and helping individuals meet their goals wherever they happen to be through the provision of long supports and services. In general, they assist individuals to have the opportunity to stay in the community and avoid in lieu of institutionalization if that's their choice. It's certainly not a requirement, but it does offer that option. So these are individuals who would otherwise be served in a nursing home or in a different level of institution. But the range of services goes all the way from personal care attendance services to things like, we talked a little bit about substance use. I mean, we do have CHESS now, which is an opportunity for people who have substance use disorders and who are homeless. So we've crossed that line, I guess, a little bit, where we're really trying to address social determinants as well as what you would more typically see in the range of home and community-based services like personal care attendants or home health aides and things like that. we're one of a menu, so DDS also, we are the administering agency, but DDS, of course, also does have home and community-based services as well as DMIS. So I think Connecticut's really well positioned, and I think you see it in some of those documents that, and under our commissioner's leadership and the governor's leadership, frankly, I think that Connecticut in some ways is leading nationally with respect to the provision and range of options for people, once again, to have a choice to remain in the community if that's what they choose. Jen, did you want to add anything?
And just the type of services obviously available from, being able to attend, adult day center or, be home with, a personal care attendant, companion, home delivered meals, a wide variety of services, where they choose to receive those services.
Jen, just a quick follow-up question to that. For the adult day services, is it only Medicaid recipients that are in the waiver program that is covered expense, or if anyone has Medicaid, is that an allowable expense under their services?
Those age 65 and older receive.
So if I'm a Medicaid recipient, right, I live with my daughter, and I want to go to a day service, and are we just talking day programs in general?
Adult day services, correct.
Okay, so I can get those services paid for through Medicaid. I don't have to be part of the waiver program.
There are, one of the state plan 1950I has adult day services as part of it. So there's some intricacies to it. So, but yes.
Okay, I'll be sending you a private email on there because there's some questions about that. So thank you. I appreciate that. Representative Johnson.
Thank you, Madam Chair, and thank you for those explanations. I just, I know that I was part of the discussion on this aspect, and I just wanted to follow up with the degree to which the state is helping children who have behavioral health disorders go to day programs in psychiatric facilities. And I was wondering exactly, or approximately actually, how many beds or how many day programs are available to students who have these behavioral health problems and can have them cared for in a NADCHOC hospital. They do it here and in other psychiatric facilities. I just didn't know how far what kind of support we're getting in those circumstances.
I'd be happy to follow up with that.
Okay, great. Thank you so much.
Any further questions or comments on long-term services? Seeing none, our final question was interested in PCAs and being able to access insurance and other benefits. I think that the response was that it is still being negotiated. And at this point, when you're in the middle of a negotiation, DSS is limited on their response. If they have any further information that they would like to share, now would be the time. So seeing none, I think we did a great job getting through all of the questions. At this point, it's 2:10. For the next 5 minutes, do any of my colleagues have any follow-up questions? I know Representative Dathan wanted to either make a comment or ask a question. Now would be the time to do it, Representative.
Thank you very much, Madam Chair. Of course, I put my question down and I'm bouncing between two Zooms here. Just really wanted to kind of follow up on the questions that we had regarding the ARPA. In terms of, in August, you approached the committee regarding, you had submitted a plan to the federal government. Did they have any changes for your proposal?
On that plan, Representative Dathan has been approved back in December.
Okay.
So we're moving ahead, and we're looking for the Medicaid authorities now to spend the dollars that were approved in the plan.
Okay. And in that approved plan, have you addressed the increased provider rates? Because I'm just trying to understand, to get my hands around that to talk to the committee about.
Yes, and I'm trying to remember if there's an appendix that articulates.
There is, Commissioner.
Go
Appendix
ahead,
2.
Mike. Appendix 2.
There's a detailed timeline, at least for the DSS rate increases that are included in the ARPA HCBS plan in Appendix 2. You know, it covers what the Commissioner mentioned, the original plan approval, but then also the additional authorities that we need to obtain to be able to move forward with the various rate increases.
Okay, I'll have a look at that, and if there's a follow-up question, I'll let the administrator and the chairman know. Okay, thank you so much. I appreciate you coming in today, Madam Chair, Commissioner.
Thank you, Representative. Representative Dillon?
Thank you, Madam Chair. And this has really been a helpful session. The responses are very thorough, but I don't know whether it would be appropriate to ask DSS or whether it's a DCF question, but on the length of stay for the hospitals which already have behavioral inpatient beds, I believe Senator Austin did ask the question about Four Winds, but I was interested in the variation on the length of stay. Like I think Bridgeport, St. V's had a very long length of stay, and I wonder if that means that we should be looking at either the case mix or whether it's about an inability to discharge someone somewhere. And I don't know if that's really fair to ask you or if it's a DCF question. But it's about length of stay and what it represents for what we're doing already.
I'll ask Bill if he has any commentary. I would say, Representative, it likely represents, or it may represent, because I don't know for certain, it may represent, as you say, a difference in case mix, and there may be some of these hospitals that specialize in particular disorders that are require a more protracted length of stay. With respect to delays in discharge, that has been an issue we've heard from the hospitals about. We've been working very hard with DCF on that. And we have instituted an intensive care management program, which is to provide assistance directly to the hospitals to facilitate transition of the children to outpatient services. So we're hoping that that program is just getting started. We've done the RFP and identified the contractors. We've been working with the hospitals to pair them up. So we're hoping that will begin to assist in facilitating discharges. Bill, do you have anything else to add on the variation in length of stay?
I agree with everything you said. I would just draw your attention to the asterisk at St. Vincent's that we were missing some data for one quarter in 2021, which may have skewed the average length of stay. So that could be contributing to the slightly higher length of stay.
Thank you. I guess that we're looking at legislation that that's pending before that would alter the current prior auth for behavioral children. I'd have to see what comes out of committee, but I don't know how that would affect the current providers or the prospective providers, whether or not prior auth is waived for inpatient or for outpatient. I don't know that. And the other, of course, is anxiety about what the Office of Health Strategy is proposing, which people are interpreting as a cap. So there is high interest in this issue, actually among some pediatricians. I'm gratified to hear that you're working on something with the hospital community. I assume that every hospital is engaged in that. Well, not every hospital does behavioral health inpatient, so there's fewer than 10, right? It's Yeah. Okay, well, I don't know if it's fair to ask you to speculate how your asterisk about authorization would be, how any of that data would be changed if we changed our current policies on prior authorizations for children's mental health. But
Representative Dillon, I think it'd probably be more fruitful if we had the actual language in front of us to have a conversation about how it might impact Husky, and we'd be happy to have that conversation once we see the actual language.
That's great, Commissioner. I think a lot of people and a lot of legislators would be interested in that too. But thank you very much. And thank you for all of this information. And thank you, Madam Chair.
Thank you, Representative. I think we all have to remember that one of the issues, the biggest issues why the length of time in the hospitals for our kids is that we have a lack of outpatient services. We don't have what I like to refer to as step-down units. DDS has been doing some work around this, which has been fabulous, but there isn't enough. So just keep that in mind as we continue to have these conversations. With that, any further questions or comments? Seeing none, because we are in a short session and a short timeline, hopefully we will not have to have another meeting with DSS. We will be able to start to go to budget items. And if there are any, we will send them over to you, Commissioner. I do want to take this opportunity to thank you and your staff for all your hard work and for being here today. We do appreciate it. And we hope you all have a great day.
Thank you, and I echo your thanks to the team at DSS.
Thanks, guys.
Thank you.
Madam Administrator, do we take 2 minutes to transition from DSS to DCF?
Well, the DCF team is in, Madam Chair, so whatever you prefer.
I'm ready.
Okay.
Is everyone on? Looks like it.
Yes, they are.
All right. Good afternoon, Commissioner and team from DCF. It's so nice to have you guys before us. This is the Subcommittee for Appropriations for DCF. I'm Representative Abercrombie, co-chair with Senator Kushner and our team here of legislators. And I want to thank you guys for being here today. I really have to start with saying congratulations. I'm so excited about the fact that the Family First has been approved. I think that Deputy Commissioner Michael, there he is, Michael Williams did a great job last night. I watched you on TV. Kudos to you guys and your team. I think it's exciting for Connecticut, and we're really proud of the work that you've done. I know this has been a heavy lift. I know it's been a few years in the existence, but kudos to you guys. Job well done. And then on the 1F, that's exciting, where we are after all these years. So again, I want to thank you to your team and even to teams before you that really had a hand in this for many years. Deputy Commissioner Williams, do you want to comment at all about the Family First before we get started?
Only to say thank you for your comments. It has been a great journey for us in Connecticut, and where we ended is good for the entire state and for all families in Connecticut. We're excited. Now the work begins with implementation.
Yeah, that's always the devil in the details, right? But thank you guys, really. This is exciting time for Connecticut, and to you, Commissioner, and your team for being here. So we thought, because we only have really about an hour, we thought that we would like to proceed is I will go over every question, and then I will ask my colleagues if they have any follow-up questions. And then if we have time at the end, we will open it up to any new questions that we might not have thought of at the time of the first hearing. Is that okay with you?
It's perfect. Thank you very much.
Thank you. So question number 1, provide the names of DCF's nonprofit providers and their scope of services. As my colleagues can see, there's an Excel worksheet that has been provided. Does anyone have any particular questions on this number 1 question? Representative Dathan.
Was the Excel workbook sent at the same time from Sue Keen yesterday at 11:28? I only see the Word document.
Madam Administrator, I'm looking at a work.
It might be me, so.
So Madam Administrator.
Not you. I don't have one either. I was looking through it also.
Oh, Madam Administrator, am I working off the wrong sheet? I don't know.
All I have is that I have the same one, Kathy. And that's a Word document. And then in question 1, they referred to an Excel workbook, and I'm not seeing that as part of
I'm sorry. I didn't know what you were asking.
I'm sorry, Claire.
My apologies. Ken, did I receive the Excel document?
Yeah, Sue, you should have. I can double check real quick, but I was real clear. I sent you everything I had.
Okay, my apologies, Ken. Somehow I missed that. So if you could resend that to me, I'll get it right out. My apologies, Madam Chair.
No, no problem. No problem. There's a lot of paperwork going around, and as lucky as we are to have Zoom, it's really hard when we're not in person. So, I guess what we'll do is there was an explanation for question 1. If anyone has through the explanation any follow-up questions, you can ask now, or when we do get that workbook, I guess maybe what we'll do is through Madam Administrator, send some follow-up questions to DCF. Is that acceptable to the subcommittee members? Yes. Senator Kushner, are you okay with that, ma'am? Okay, thank you.
Yeah, I'm Melanie. If there's anything else you could send, I sent what I thought was the complete set of documents to Sue Keen. So I apologize for any confusion there. I'm not sure quite what happened.
And I just flipped you another email with just the attachments. If you want to flip that over to Sue Keen, I just sent it to you again.
So why don't we move on to item number 2 while Susan's getting that, and then we can, because the workbook, Ken, correct me if I'm wrong, the Excel workbook has to do with only question 1, correct? Okay.
Correct.
So
Yes.
Is that okay with everyone if we kind of skip that until we figure that piece out and then go to question 2? Yes? Well, nobody's saying no, so I'm going to take that as a yes. Sorry, I know everybody's on multiple Zooms. I apologize. Question number 2, what are the current utilization rates of DCS extended day treatment programs? I think Representative Johnson or Representative Dillon had some questions about this. Do you have any follow-up questions or comments, colleagues? Seeing none, moving on to question number 3. There's a lot of information here. This has to do with, please explain how the urgent care centers and the acute crisis units will be used, and is there any impact on the therapeutic group homes long-term? Commissioner, do you just want to, so that people that are watching this can also hear about why you feel there's no impact on the therapeutic group homes and what the difference is between them?
Thank you for the question. The difference is the level of care. And so they are two different levels of care. The urgent crisis centers are proposed to provide a safe and effective alternative to the emergency department. And it was our best thinking around how to start to alleviate some of the surges that we saw during the seasonality of the surges in the ED, but how those were compounded during the pandemic. So in the interest of time, I will say that the urgent crisis centers shall be receiving children ages 5 to 18 or 21 if in DCF care that are experiencing a behavioral health crisis via walk-in, police or ambulance drop-off. They will triage the youth based on risk and need, provide de-escalation, crisis stabilization, offer thorough assessment and appropriate levels of care, and develop a crisis safety plan collaboratively with the family based on the assessment report results. The coordinating care for the children and families will receive an appropriate level of care and service type to meet their needs. The subacute crisis stabilization piece that will go along with the urgent crisis centers is a program expected to provide a safe facility for youth experiencing a subacute behavioral health crisis and to stabilize them over a period of 1 to 14 days. It is anticipated that these will each have a 12 to 16 bed capacity. They will receive the eligibility criteria in terms of the age, similarly to the urgent crisis centers. They are intended to engage children in de-escalation and stabilization, full diagnostic evaluation and assessment, provide medication administration and management as needed, provide individual group treatment to prepare a child to return home, school, or their community, and work collaboratively with the family and other professionals to support the child's discharge. And based on those results, the coordination of care to receive appropriate level of care of discharge will also be expected of a stay there. If there are any specific questions to this new level of care, I also have subject matter experts from the department here with me.
Have you started the process for an RFP on this?
Tim, Melanie, where are we on the RFP for this, Mel?
We have absolutely started the process. We had to design the service first, Representative, and the service is now designed and the actual RFP document is being drafted from that service design.
And when do you expect to get that out?
I would defer to Tim Marshall, our content expert on that, but I'm guessing within the next, I'd say within the next 3 to 4 weeks at the latest.
And when you do an RFP for this particular service, what's the turnaround time?
By OPM procurement standards, we have to have that RFP posted for a period of 7 weeks before we get proposals. We do keep that timeline pretty tight. So 7 weeks from the day we release is when we'll get those proposals. We usually need about a month to turn them around and get negotiations completed and contracts awarded.
Okay, thank you. I'm sorry, I'm writing notes at the same time. Representative Walker.
Thank you, Madam Chair. Hi, DCF. Hi. I'm sorry, I'm bouncing from multiple Zooms too. On this particular item, I noticed in the budget that you had an increase in community care coordination of 7.9 million, and then you also have an increase in community-based prevention. Are either one of those items in this RFP, or is there another item that where are you getting the funds for this?
Sorry about that. Melanie, can you address the line items for this particular, the first one in particular?
Yeah.
So these are being funded through our last allocation of ARPA.
Okay. All right.
So you would not see those in our regular budget. I can speak to the community kid care account if you want to right now, or there's a question a little bit later.
No, I'm just trying to figure out where the funds come from, and you're saying that this was in ARPA. This was in ARPA funding that you're getting these dollars for?
Yes, ma'am.
Huh. Okay. Was this the Children's Mental Health Initiative?
It's one of the initiatives off of that initiative.
Okay.
Yes.
That was 10.5?
Yes, ma'am.
Okay. All right. It says that you've allotted 4 million. Is that 4 million? Is that the amount that you're using for this sum?
Yes.
Okay. Okay. Thank you. Thank you, Madam Chair.
Thank you, Representative. Susan Keene, Madam Administrator.
Thank you, Madam Chair. Ken has forwarded the documents to me, and I have since forwarded them to members of the subcommittee. So you now have what you need for the discussion on item number 1.
Thank you.
Thank you. I think we'll continue here to give my colleagues the opportunity to open that document, and then we'll circle back around. Is that okay with everyone? Okay. Item number 4, please provide details on where the 16 subacute crisis beds may be located and what organizations. So I don't want to speak for DCF, but I know that our contracting rules are pretty tight on an RFP. Can you give us any more detail on this?
No, but I can say that the initial RFP based on proximity to the concentration of kids at Connecticut Children's would be looking to the Hartford or greater Hartford area. And then the subsequent proposal for the additional 3 subacute subacute entities would be as part of the RFP later on.
Senator Ciccarella, I think this might be a good opportunity for you to ask your question about your nonprofit organization.
Thank you so much. I really appreciate that. So let me take this earbud out, which is another Zoom, so I could do this correctly. So I was speaking with a few of my colleagues who represent Eastern Connecticut. And there is an agency or a nonprofit, it's Child Family Agency, and they're out of Groton. They do really good work specifically with children with psychiatric issues. And in Pawcatuck, which is probably about a half an hour, 45 minutes away from Groton, there is a large need, just like in so many other towns across Connecticut and cities, that need these services now more than ever for our children. And unfortunately, the children that are in Pawcatuck have to go to the Groton location to get this type of treatment or be sent to the other nearest location, which is over the state line. And that creates a lot of insurance issues and other challenges for these families. And also there isn't, not only is it a pretty long ride, but it's not even on a bus line to get these children and the families to this nonprofit to provide them with these services. So they were looking for $250,000. And I spoke with Allison Blake, who runs the very successful nonprofit in Groton this morning. And she was saying that the $250,000 would allow for staffing and other services to be rendered out of a building which was formerly a middle school. There was 2 middle schools in the area, one shut down. The one that was shut down was now administrative building and does have room. And the local administration and elected officials are on board to bring in this nonprofit to provide these much needed services to the children. What they're looking for, again, is the $250,000 specifically in the DCF line item. That's, I think it's just over $16 million, and it's for grants for psychiatric clinics for children. And I was just wanted to get it out there and get that on the radar, because I just think it would be so beneficial for the children in Eastern Connecticut. And I think it would do a lot of good. And I just wanted to get that on your radar. And Representative Abercrombie, I really appreciate your help of help me navigate through this process. I really do appreciate that. Thank you.
My pleasure, Senator. So, Commissioner, the question is, is that particular line item, is that done through an RFP or is that a grant proposal line item? How would we, and this might be a longer conversation, but how would we put in for that particular grant for this organization?
So I can begin the question and then ask the CFO to comment specifically related to the line item. One of the questions that was posed, Senator, in the past, and I believe Senator Austin has also challenged us and really asked about those areas of the state that don't appear to have the same level of resource for particularly children's behavioral health needs. And I feel like that it's also similarly around the eastern part of the state. With specifics to that particular dollar amount and a line item, Melanie, I don't want to get too far over my skis or say anything that I'm not permitted to from the procurement process, but can you comment on the senator's question related to kind of the needs in that part of the state?
It would absolutely have to be an RFP. I would actually pull Tim Marshall in because I do believe you're talking about an outpatient psych clinic for children. So that is beyond just DCF. That requires licensure by DPH. Tim, certainly tell me I'm wrong if I'm wrong. But that requires licensure by DPH. But we would, in order to initially fund that, we would have to go out to bid. We couldn't.
So I think I think this needs to be a longer conversation, but I would like to put it on your radar that the senator will be reaching out to you to find out what the process is. And I think you're absolutely right, Commissioner. You know, there's parts of the state that really need our help at this point because the lack of services out there has been really hurting our children. And I know I'm speaking to the choir, but I'm here to support the senator on his thoughts for that region of the state. So, you know, we will be sending an email just to ask about the process and how we move forward.
Thank you so much. I really appreciate your guys' time and participation and kind of educating us, not only in this matter, but many others. Greatly appreciated.
Thank you, Senator. Commissioner, were you talking about? I'm sorry.
I was, and I just want to make sure that the senator heard also too that it would be follow up with DCF and DPH, so Department of Public Health.
Yeah, because we have to make sure where they are in the licensing,
right.
and then if they were going to do an outpatient clinic in another community, how does that work? So you're right, a little bit more complicated than just throwing dollars at it. Yeah,
absolutely. And I do think, I apologize for interrupting, but I do think that their nonprofit that provides these services in Groton, I think they fall in that same chunk in that line item. So I do think they're already, maybe I don't want to say in the system, but they're already participating in that grant process within this line item. But I'll get clarification and I'll be very happy to speak to you offline about this.
Yeah, I think the questions you need to ask the nonprofit is, does their license extend to them to other facilities? Because usually license from DPH are to one specific location. So I think that's, and I don't want to speak for the commissioner, and Melanie, but I think that's kind of what they're referring to is we have to see how their license, does it allow them to go into the other community? Senator Austin?
Senator Ciccarella, what is the name of the group? I'm sorry, I was doing another Zoom.
It is Children and Family. It's the Children and Family Agency out of Groton. Allison Blake is the president or operates that.
Thank you.
Thank you.
Thank you very much, Madam Chair.
You're welcome. Any further questions or comments on that particular one? Seeing none, we'll move on to item number 5. What is the current utilization of the emergency mobile psychiatric services by region, time of day, and time of week? I just want to say thank you so much for this detail, especially when you break it down into regions. It's so helpful to understand where we are and where we can do better. Are there any questions from my colleagues on this particular item? Representative Dathan.
Oh, I see Senator Austin raised her hand first. So
I think she forgot to take it down. Senator Rhea, okay. Representative Dathan.
Thank you. Thank you so much for pulling this together. I know this is a big issue that we're seeing throughout the state, and it's only getting, it seems like it's only getting worse. Do we have an indication about these emergency mobile psychiatric services are broken out between pediatric and adult?
Yes.
And I'm sorry to ask a follow-on question, but I had a mental health forum last week, and this was something that folks were asking about. And also, do you have that broken out by county? Because I know we have a lot of concerns where I am in Fairfield County, and I'm sure other folks do as well.
The quick answer to the first question is yes, there's definitely a breakout between the adult mobile psych and the child and youth mobile psych. The adult mobile psych is managed and contracted through DEMIS, and then we have the contracts for the 6 providers that cover the children's behavioral health, children's mobile psych. On the first chart, the breakdown by region is there, but I want to get to your question on county because I think the question is a little nuanced. It's a bit different than these regions.
Nuanced. And,
yeah.
You know, if I don't know if everybody in the committee cares about what's going on in Fairfield County as much as I do. It's important to me, and I'm sure the other folks on the call would like to hear what's going on. In particular, you know, I know we have an issue with one of our hospitals is closing some of their psych beds. And so I'm very concerned about the reliance on the mobile facilities rather than necessarily just what's going on within the hospitals.
Mm-hmm. Tim, can you comment on which of these would cover primarily Fairfield County? You're more familiar with the actual providers on mobile psych.
Yeah, I was just looking it up off the top of my head. I believe it's the out of Bridgeport and the out of the Stamford area. So we have there's 6 contractors, 14 sites around the state. They're all required to be able to get to any town or city in the state within 45 minutes. And I believe Fairfield is covered out of the Bridgeport system, and it's a subcontract with Stamford.
Yeah, I was actually, you know, I'm represent Norwalk, so I don't know if you have it even that more nuanced. I was kind of just thinking Fairfield County, which would cover both Bridgeport and Stamford. But if you do have that by city, that would be interesting, and I'm sure others would like to see where their towns and cities stack up to.
Representative, can we follow up with you directly specific to your question? And then okay.
Carry on. We have limited time today, but I just, I saw this answer and I wanted to follow up on that. Thank you so much, Commissioner, and thank you, Madam Chair.
And Representative Abercrombie, I just want to draw the committee's attention to the bottom of page 7, where it breaks out just the percentage of calls that have come by shift. And then also recognize the fact that because we haven't had mobility 24/7, it may have also created a behavioral shift of people not calling during that time. The availability of 24/7 mobility may change those shift percentages.
Thank you. And I think that's what my colleagues are trying to ask about was, you know, what time of the day are they being used the most? And, you know, is that where we need to put the most resources? But I think you're absolutely right, because people don't know that it's 24/7, you know, are those numbers going to shift? And I think you're right as we go forward. Any further questions or comments, colleagues? Seeing none, item number 6, what are DCF certification standards for therapeutic group homes? I think this was a Representative Johnson question. I know she's dark on the screen, which means she might be on another call. Representative Johnson, do you have any follow-up? Okay. Does anybody have any follow-up questions on the therapeutic group homes certification standards?
Representative, can I just make one particular tweak that I think will also be helpful for those that are looking at the response to this question? And it is the term certification DCF licenses this particular level of care. And so that, you know, the licensing process is what happens with therapeutic group homes as opposed to a certification. So I want to make sure that the committee is aware of that terminology.
Thank you, Commissioner. If Representative Johnson does have the ability to come back on, we may have to go back to that particular issue. I'm pretty sure she was the one that asked the questions. And I do want to just let everyone know that my colleagues are on multiple Zooms. And so, you know, we need to be a little bit flexible with asking questions. So I appreciate that, Commissioner, from you and your team. Item number 7, The level of care assessment is determined by Beacon. Please provide a copy of a blank assessment. Does anyone have any questions about this? Seeing none, we'll move on to item number 8. Oh, sorry, Tony.
I haven't read it all, so if I do, I'll come back because we just got it. Okay.
Sure. No
Thanks.
problem. Item number 8, do therapeutic group homes have an extended day treatment component? If not, why? Commissioner, do you want to just give an explanation of this?
I can, the short answer is typically during the day, children are at school. And so a day treatment may be getting conflated with other levels of care. I have Dr. Linda Dixon, who is on and is the subject matter expert in this area, who could provide a better explanation than what I just did. So Dr. Dixon.
Yeah, we have each therapeutic group home has a full-time clinician, and their hours are flexible to meet the needs of the students. But like Commissioner Durantis just said, most students are in school during the day, and the hours of the clinician are flexible.
Senator Austin.
There you go. I got off. Finally, it took me a while to get off of mute. Commissioner, I have a question. I had a constituent who, young high school kid, off of got into a dispute at the school and is out of school for a long time. And the school is providing them with school resources relative to the education component, about 4 hours a week, give or take. I asked them, what are we doing to make sure this young person has resources available to them that extend beyond their educational component? And I don't know that this exactly fits into where we are in the questioning section, but it seems to, and they said nothing. There is no ability for them to provide any resources. And so we have this young person who had a significant issue, seems to me, has some issues going on. I happen to know that the family is on the lower socioeconomic scale. And it worries me that we would have a high school boy not receive any services. Would this be a DCF call, or would this be, are we going to say this was just an educational issue and we're going to have the kid come back next year and hopefully they've gotten better? This is something that I've always struggled with in this age range of young people. I brought this up to you before, that this age range appears to not have enough resources to address issues, and it worries me very much so.
So it doesn't sound as though the child is in a therapeutic group home. So I just want to make sure I didn't miss that component of it. Because
no, but I'm saying, wouldn't wouldn't there be something that could be done with this? They're not in a therapeutic group home. I apologize if I haven't gotten it in the right section of this, but it seems to me like we're willing to throw away some of these young people, that they're problems, so we don't really want to deal with them. And maybe he needs a therapeutic group home, maybe he needs a PHP, maybe he needs something. But if the family is, and I find that what happens is those families that are on the edge, they have a little bit too much money, so don't qualify for like a Husky, and they don't have enough money to have a healthcare plan that provides some sort of treatment. I'm just sort of running this by you because I'm worried about this. I think that a lot of schools just don't want to have to deal with young men who have anger management issues that I think are related more to their ability to cope with things that are going on within their lives. And I don't know if it's a DCF issue or if this is an issue that where would somebody go to get the help necessary?
Yeah, I absolutely appreciate the attention and kind of targeted to a specific affinity group. Our work related to teenagers is something that, you know, we have broadened in terms of the service array. We certainly don't, you know, want to throw kids away because we know what that means. We know that if children don't get their needs met, that it ends up manifesting in another system, you know, as they start to get older. So as I think about what you are describing, it sounds like the child their youth could benefit from individualized wraparound care plans. And those are the things that we can work in conjunction with 211 to identify really what the specific need is for this particular youngster. And then, you know, help kind of weave those services together to be able to meet his and his family's needs. Tim or Linda likely would be the best subject matter experts. You've heard what Senator Austin is asking about. I can tell you also, we can speak offline specifically about the family that you're speaking of, but in general, if one of you could reply, that would be great.
And I'll give them a moment to reply. I want to make sure that I'm not saying you're throwing kids away.
No, I didn't hear it that way. I didn't hear it that way.
Societally, and I've been very careful not to release specific information about the family because that's their personal business, and I don't think it necessarily needs to be online.
That's right.
I'd be happy to talk about this, but I've talked about this age range of kids that I think can have significant problems, but can be actually moved into a different direction than the trajectory where they're moving right now.
And I certainly don't disagree. Tim?
Yes, I just would add a couple things. In any situation, the school is bound to provide more than 4 hours a week of education. So I would start with that. That would be very problematic. But in addition to that, I would agree with you, Commissioner, and that a care coordination referral for intensive wraparound, because they really do try to use informals and family supports to figure out how to resolve is any of the issues that are there, and they are able to then do a needs-based assessment and then make the referral to the appropriate level of care and get them connected if needed. The biggest challenge, I will say, with all teenagers, probably beginning at least at 14, 15, is it's really hard to make them do something they don't want to do. And so you could provide a lot to them, but if they're not willing to do it. So I would just say that, but I think care coordination is probably one of the best, and we could definitely help you connect the care coordination. We have some great providers in the entire East, so we'd be happy to connect you.
And thank you for that. I recognize that teenagers are difficult. I also recognize that sometimes when someone says no, you have to go back 2, 3, 4, 5, and 6 times, because it's far better to find something at this age than it is to find something at 22. So and a lot of times the mistakes that are made between 14 and 22 cost jail time. And that's much more expensive and has far more long-reaching consequences to that particular person. So I appreciate what you're all saying. I just want to say that this is still my concern, is this age range right here is something I think that we have to have a concentrated effort on. But thank you very much for that. And I'll get in touch with you, Commissioner, afterwards. You can tell me who you want me to talk to. Thank you.
Thank you very much, Senator.
Thank you, Senator Austin. Any further questions on this particular item? Moving on to question number 9-10. Explain how elimination of differential response system account and the creation of a new care coordination account, along with the reallocation of funding, is beneficial to Connecticut. And then the second part of that question is, will this change eliminate family assessment response or build upon it? I think because this is a short answer, Commissioner, if you could, for the record, just go through this, that would be great.
Thank you very much. The DRS system is not being eliminated at all. Currently, this account funds the contracts for our family assessment response services provided through Integrated Family Care and Support program, further built on the success of FAR. The governor's proposed budget allocates the Integrated Family Care and Support program funding from the DRS account into a newly established Community Care Coordination account. The funding for FAR services contracted will remain in the DRS account and the current funding level. As it relates to the need to shift this, Melanie, can you just explain really succinctly what we did here?
Absolutely, yes. So we are not reducing the DRS count at all. We're shifting the funds into the new Community Care Coordination account, and we are only shifting the funds for our current IFCS model of care. What that's going to do is create the pathway for us to implement the care management entity that we need in order to start billing for Families First services. So there's no funding reduction, there's no funding addition, it's just a shift in money with the FAR providers being kept whole.
So let me just speak from an appropriations point of view. I find it problematic when we put too many buckets of money into one line item. I liked it that I got to see each program and be able to, from there, figure out, do we need to add dollars? How many people are being served? So, I don't know from an approach point of view if we're going to accept this or not. I understand what you're saying about the Family First dollars, but it always makes me, and I'm just speaking for myself, it always makes me very uncomfortable when we try to merge too many programs into one line. But I understand what your thought is behind that. Any further questions or comments from colleagues? Seeing none, we will move on to the next item. Question number 11. How many families were helped by FAR, which is, I hate the acronyms, which is Family Assessment Response in 2022, and how many are anticipated to be helped in 2023? I think this is kind of self-explanatory. Do any of my colleagues have any further questions or comments? Seeing none, moving on to item number 12. So for the 3 board-in care accounts, the individualized service account, please provide the starting caseload figures, the original 23 funding, the biennial budget compared to the current caseload, and the funding estimates in the 23 revised budget. To explain the reduction of 15 million approximately related to re-estimates of caseload driven. I think the concern around this line item is this is the line item that every year, every budget cycle gets reduced. Then I think we all get very concerned when we start to reduce this line item. I really appreciate the explanation and the graph that you have provided for us. But I think that we always just want to make sure that we are doing the right thing when we start to close some of these beds. So colleagues, any further questions or comments on this particular item? Representative Walker, do you have any? I know you're on another Zoom, but I know this is kind of near and dear to your heart. Okay, so we will move on, but if Representative Walker gets the opportunity to come back on, she may have some follow-up questions. Item number 13, what DCF programs address the rise in the trafficking of children and youth in Connecticut, and what is associated funding for these programs in this budget? Could you kind of just give a high-level explanation of this, Commissioner?
I will, and I recognize too that this was another area that Rep. Walker had asked for some additional detail on. I'm going to call on Senior Administrator Deshonda Guerrier, as this falls within her shop, to succinctly give you some feedback on that question.
Thank you.
Sure. Good afternoon, everyone. So the programs primarily are Love 126, as well as our vast network of DCF heart liaisons that we have outposted in our regional offices, in addition to the partnerships that we have with community providers to include law enforcement, state's attorney's office, educators. Primarily, our goal is to help train the masses, if you will, through a train-the-trainer process that allows them to do recognition of human trafficking. And so there is a reporting mechanism through our care line when we feel that our youth are at risk of that. And so when it comes to our attention, if it rises to the level for an investigation with regards to caregiver, then of course we're going to follow that pathway. But in addition to that, we have an obligation to look at all reports, even if it is not inclusive of the caregiver. And so in working with our contracted agencies to provide services, we try to do a rapid response, which allows us to then work with and do a quick assessment of need with these young women, but also men are victims too, to kind of assess where they are, what they need, are they willing to receive those supports? Additionally, we have MDTs, which is where we bring all of the various professionals together to really staff what we know about the youth in the cases to see if we can get some clinical interventions in place while we have them captured, because you know that sometimes if the youth is not ready to receive the services that are offered, there's not much that we can do but to give them information and lend our support to them. There are numbers that are included in the response with regards to where we are allocating those expenditures and dollars to support this population.
Thank you very much. I think if Representative Walker has any follow-up questions on this, when she has the opportunity to look at the documentation, I'm sure she will follow up on that. Representative Betts.
Thank you, Madam Chair. Could you explain why people would not want the service or why they don't need it? Or is it, or am I misunderstanding that they simply don't want it?
So I think that what was shared kind of also dovetails onto Senator Austin's question. Adolescents likely have a harder time acknowledging the need for help, particularly kids that are trafficked, because they're not, we know what it is. We see all the signs. We are able to identify what those things are that really kind of are the hallmarks to human trafficking, yet the child sometimes in the center of that doesn't recognize the exploitation that they are going through. So that's why it's important for us to make sure that, you know, schools, community providers, law enforcement also have this curriculum so they can identify those signs when they see them. So, but if you ask a child or a young person who is being exploited in this way, are you being trafficked? They may not be able to believe that the extra presence that they're getting from this older gentleman or those types of things that they're doing are actually things that are exploiting them and actually victimizing them. So it's not a choice in a way that we typically would understand choices as an adult.
And thank you, Commissioner, and these people who are individuals, do they have, even though they're being trafficked, do they have any siblings, or is there anybody that they also relate to in this kind of confusing state?
I think that one of the things that predators prey on are those kids that, you know, have detached familial relationships, and then you see someone who can kind of move in and see those vulnerabilities, and that kind of makes them ripe for being victimized in this way. It is kids that kind of feel like no one else is listening to them, and they get a lot of attention from somebody who was looking to exploit them in this way. So, and unfortunately, the reason why this particular affinity group is housed within DCF is because children that are in foster care or have a high likelihood of being identified as having been trafficked. However, our reach is outside of even the kids that are already, already a part of the DCF caseload, and this net is very broad. So as you can see, it looks like we have quite a bit of community expertise as it relates to really trying to get our arms around this.
Okay, thank you very much, Commissioner. Thank you, Madam Chair.
You're welcome, Representative. Any further questions on this particular item? Seeing none, we'll move on to questions number 14 through 16. Which programs and services are included in the Family First Prevention Services Act? Please provide a copy of the plan along with the executive summary. And does The Family First Prevention Services Act includes services for homeless families. Does that particular program address the post-traumatic stress disorder needs for homeless children? I think this might have come from Representative Johnson. So Representative Johnson, there's a lot of material here. Do you want her to the commissioner to summarize, or have you had the opportunity to look at the material and do you have follow-up questions?
I have not, unfortunately, had a chance to look at the material at this point in time. She could make a quick summary and then I can look at it. However you want to proceed is fine, and I will definitely take the time to look at it. It's just been kind of a very difficult week for me so far. So
No apologies necessary. We're all doing double work here. Commissioner, I think because of the programs that are included are self-explanatory, I think if you want to talk about the homelessness piece of it, I think it's really important, especially to Representative Johnson. So if you want to maybe address that, I think it might be helpful. Commissioner, you're on mute, ma'am, for some reason.
Wow, and that was a great explanation I was giving too. One of the parts of the Connecticut plan that identifies what makes a particular population a potential candidate for foster care, unstably housed or homeless youth is one of those. And so what you'll see when you have an opportunity to take a look at the plan, and as you indicated, Representative Abercrombie, the Connecticut plan was approved by the federal government this week, which we're really, really excited about. That, you know, unstably housed and homeless youth are identified candidacy pools. And so those evidence-based programs that are listed there that are part of a much larger clearinghouse will be able to be reimbursed if the kids that are identified under that particular candidacy category utilize these that are bulleted out there. So once you get a chance to take a look at particularly the executive summary of the prevention plan, you'll see the carve out of all of the different types of kids that we hope to capture in these areas.
I just want to thank you so much for that work and the recognition that these homeless children are in a bad spot, and that work that you've done. I did have a quick glance at the acceptance by the feds on your work there, but I haven't had a chance to really get into the weeds. But thank you again for that. That means a lot to I think everybody. Thank you.
And I think as we continue to build out our prevention work, all of the different nuances and different groups of kids across Connecticut that might fit into any of those categories would truly benefit from services that don't necessarily have to come through the DCF foster care door in order to get services, because what we've heard loud and clear is that families and communities want that outside of our doors.
Thank you, Representative. Representative Betts?
Yes, thank you, Madam Chair. And the commissioner touched on something that at least I'm not familiar with. You have some successes with these kids, yet how do we know, either anecdotally or statistically, how do we know that this is something we should either be investing more in or should be showcasing as a successful program versus just using numbers and we're not quite sure how to evaluate it?
So that I can answer that in two ways, specifically related to the Family First legislation that we were just talking about. There is an evaluative component that will be a part of this whole process. So now that we are building out our prevention continuum, we will be able to see in real time exactly what you're talking about, the efficacy of the programs that have been identified. We'll be able to track kids that got these particular services to see if they indeed did not come into, I'm speaking a lot of double negatives here, but making sure they did not come into foster care. We'll be able to track that with the structure that's being built out. For contracted services within the DCF service array, we have a framework that we evaluate to determine the service types outcomes as it relates to kids and families who use those services. Melanie, can you give a really quick high cut of the SOAC process of how we measure the outcomes related to services?
Oh, happily, yes. So SOAC stands for our SOAC Service Oversight and Advisory Committee. What it does is it convenes a multidisciplinary group of DCF staff from different venues within DCF, as well as our provider staff, as well as former users of the service type, so former consumers. And together, they look at each one of our 80 service types and they develop standardized, strategized performance outcome measures for each service type. Once those are developed and in contract, our providers start reporting against them, and then they come back to SOAC at different intervals to evaluate the efficacy of our services.
And that's very helpful, but I guess what I'm looking for, and maybe for confidentiality reasons, it can't be done, but for example, in Bristol, they get the Boys and Girls Club will have a Youth of the Year, and you go back and track their history and how they had a bad home experience or they were homeless, and then they've gotten to this point, and then they talk about what they went through. But what made the difference was the services or programs that you offered, but we never know about. And I've seen a couple of these kids, and you would never believe that they'd had the trouble that you heard about in the past. But what's gratifying is not only seeing what they're doing now and how they're moving forward, they want to help others, and they might even actually be volunteers in your system. But sometimes I think putting a human element in it helps a lot of us understand the good work you're doing, or something that we might want to, spread around so people will get a broad picture of the program as well as the individual. Because there are successes, I just don't think that we know a lot about them.
That's exactly why we include people with lived experience. And we've actually been calling that lived expertise, because when you've been through it, it's a better way to inform a system of what it actually needs. Also, too, we have spent a lot of time within the department on what's called enhanced service coordination. And really quickly, that's matching the needs to the services, because we found out in the past that sometimes families or kids are just referred to the quickest service, which may not necessarily be the one that meets the needs of that particular child or family at that particular time. And that the system itself has biases, that if I had a bad experience with a program for a family on my caseload, I might not ever go to that provider again because of that bias. Conversely, if I had a great experience with a provider, I might refer everybody there, and they may not necessarily meet the needs of every individual family. So we have really spent a lot of time building out enhanced service coordination, as well as hearing from people with lived experience that can help guide and direct the department to measure the efficacy of our services. So I appreciate the question.
And I appreciate that, Commissioner. I think what I'm asking for really basically is going to recognize the work that your staff is doing, is giving us the opportunity to kind of either cite examples or see in some way that, wow, what an improvement it has been for this child going through the system. The state or DCF has really done something well, either by itself or with other programs. But people, instead of saying, why aren't you addressing this? You can start talking about the things you have been doing that are working, and gives it a little bit better balance.
So we publish a newsletter every month called The Spotlight on What's Right that does exactly that, with the permission, because, as you indicated, confidentiality sometimes prevents us from talking about specific cases, but with the permission of the person, that we target articles to our 700 people on our distribution list that can read specific examples of when things go really, really well.
Okay, just to increase your cost, could you put me on the mailing list for that?
I think you are, but we'll get you on again.
Yeah, all of our legislators are, and I think at times it may go to your spam or secure email. So we will work on to ensure that everyone knows that they are being sent.
Thank you. I've not seen it, so that's great. Thank you. Thank you, Madam Chair.
Yeah, you're welcome. I'll just say publicly that I read them. And I usually respond to Vinny on the ones that I'm really, really excited about. So kudos to you guys. And yes, all legislators do get that, but you might be right, Ken, that sometimes it might be going to someone's spam. I haven't had that experience, so hopefully, you know, the rest of my colleagues also. And sometimes they don't know what they're getting because we get so much material. So thank you for that. Any further questions on this particular question? Seeing none, we'll move on to question number 17. How does DCF go about hiring its social workers? Commissioner, there's a lot here. Do you want to just talk about the first bullet that talks about the DAS talent solutions?
Absolutely. Deputy Commissioner Jody Hill-Lilly has worked extensively on this, and she is my subject matter expert and can respond really quickly to this.
So sure, good afternoon. So as you know, we centralize HR, and we work very closely with DAS Talent Solutions, who initiates the recruitment process for our selection of all of our staff, including our social workers and our social worker trainees. And so for any given position, we have up to about 1,400 to 1,800 applicants. So we certainly have no shortage of interest in our positions here. And so we work with Talent Solutions and our HR business partners to make sure that the applicants are qualified for the jobs that have been posted. And we work in conjunction with them to select the ideal candidates. And so there's a lot of information here in the provided documentation, but there's a whole certification of the list process. And then we have to make sure that we are interviewing the most qualified applicants. And then we go through a series of interview processes to make sure that their background checks are cleared. And then we facilitate the hiring process.
Thank you. Any follow-up questions, colleagues?
And Representative, I will add too, we are also working with the provider trade associations, because in those instances where we have people that may not be a match for DCF, we know that the workforce crisis is upon us and they may fit with one of our contracted providers. So we're excited to be able to kind of share in some of that.
Thank you very much. Any further questions? Seeing none, we will move on to item number 18. What is the salary range for a new social worker? I think this is great that you have a training program, and I think it's a little self-explanatory what the salary is. Any questions, colleagues? Seeing none, moving on to question number 19. How is DCF working with nonprofit providers to address DCF staffing needs and their staffing needs? Oh, it's there twice, sorry. Their staffing needs, sorry.
So Jody, pick up on that again. I think I stole your thunder a little bit there. Go ahead.
Oh, no, not at all. Not at all. So I think it's safe to say that we share a concern about the workforce challenges across the state of Connecticut. And we meet regularly with our providers to come up with strategies to address these challenges. So we facilitated work groups with providers to brainstorm around recruitment strategies. We've begun to evaluate minimum qualifications to see if there's any wiggle room there. We have set up a specific work group within our racial justice work group to address challenges that the providers are having. And we are looking at any kind of flexibility that we can provide within the contracts of our providers to attract staff. Recently, we noticed a little bit of a conundrum in that generally the state offers or asks for a 2-week notice before we hire someone. And we heard loud and clearly from our providers that 2 weeks isn't enough to terminate with their children and families. And so hearing that feedback, we adjusted our standards to reflect their desire for a 4-week notice if somebody from the provider community is hired by DCF. Likewise, the commissioner also noted that what we've started to do is to begin to have discussions, and we will soon be meeting on how we might share candidate pools so that folks who are offboarding at DCF or who, for whatever reason, were not selected for a DCF position, that we might share the candidate pools, because just because you're not hired at DCF doesn't mean that you wouldn't make an incredible candidate for our providers. So we are equally as concerned about the workforce challenges and definitely are partnering with our providers to address that concern.
Thank you very much. Representative Walker.
Thank you, Madam Chair. I have one question. The salary ranges that you have at DCF, how do they compare with what the providers are offering out there? Do you know?
That's a interesting question, and I probably would pump that to Melanie to talk about the actual salary ranges compared to our providers, but I would venture to say that they are higher in general. But go ahead, Melanie.
I would add before Melanie chimes in that it depends on what positions we're looking for. We're looking at if we're talking direct care versus our social worker trainees, or depending on the type of work that they do. When you get to the clinical or administrative staff, it kind of switches.
So, okay. The reason why I say this because of the fact that a lot of the nonprofits are struggling, but their take is a little different. Their take is that you guys pay much better than what they do, and that's part of the problem why they're struggling with trying to get people to fill those positions. So I just you have Melanie, do you have any ideas, or Jody, do you have any ideas?
The commissioner and the deputy commissioner basically said what I was going to say, but very much so, yes, for direct line staff, apples to apples, the state does pay more than our nonprofit partners. When you start moving up into the clinical realms and more so when you get into the executive level, that balance absolutely switches.
Well, you don't have clinical except for maybe in a couple of your hospital locations, and so that would be appropriate. Okay.
Oh no, we do, Rep Walker. We have the regional resource groups that have clinicians in every one of our area offices. So licensed clinical LCSWs. I forgot I can use that acronym with you. We have LCSWs and supervising clinicians in all of our area offices.
Oh, okay. All right. Okay. All right. Thank you, Madam Chair.
You're welcome, Representative Walker. Representative Betts.
Thank you. This has been a very interesting session because in public health, we've heard a lot about the need for hiring more people in social work, et cetera. And one of the things that it's being seriously considered now is having a reciprocity agreement with other states to come in and be able to practice in Connecticut. And I was wondering what your reaction would be if that did move forward, and whether it would be successful in what you're trying to accomplish.
Again, it would matter which type of licensed role. So for example, when I was the office director in Torrington in the northwest corner, it wasn't uncommon for there to be staff from Massachusetts who came to work for us. Also too, in the Danbury area, we have quite a few staff from Westchester County. There is a count we can provide the committee on how many out-of-state staff we currently have, but we would definitely be open to that if it's convenient. I think one of the things we've had to recognize right now is that the workforce needs are changing in health and human services, and we have to adapt to that.
That's an excellent point. Okay, thank you very much. Thank you, Madam Chair.
Thank you, Representative. Any further questions or comments on this particular line? Seeing none, our last question number 2021. The question was asked, how many children lost a family member to COVID or to an opioid overdose in the last 2 years? DCF response was that they don't have the capability to track these deaths directly related to instances generating a Child Protection Service report. I think this came from Representative Johnson. I think what she was trying to look at is the trauma, right? So how many children are experiencing trauma because of these deaths? Representative Johnson, was this your question, ma'am?
Yes, thank you, Madam Chair. Thank you for that. It was because I believe that one of the things that we were really good at doing a couple of years back is to create a mental health first aid for educators, for students, especially that had post-traumatic stress disorder from the loss of a parent, being homeless, those kinds of things. And so I was wondering if there's a way to track that, or if we should try and track that sort of thing so we have more definitive data on that sort of stuff. And I wasn't sure whether DCF was doing that and if there was a way for us to be able to do that. I do believe that there is a lot of trauma involved, and I don't know as though, as you know, I'm in the Education Committee, whether or not, this is being addressed with the teachers so that they see a behavior problem, but they may not know that it's due to trauma. And that's kind of like where I was going with that.
Your question allowed us, Representative, to dig further on what data points are captured so we can build the service system to be responsive to the numbers of kids who have been impacted by those two very real epidemics that have faced us in Connecticut and nationwide. I also wanted to share with you that DCF co-chairs the Alcohol and Drug Policy Council with DEMAS, and that the data that is collected there is also another area that we can kind of start to look at to flush out what you had asked. Joshonda, our senior administrator over clinical and community supports was kind of looking to see if the DPH person who gathers some data can offer some insights as to, what the role of I won't even try to answer the question. Joshonda, do you have any more information on this one?
No additional follow-up, but as you indicated, we'll continue to work with our partnerships to see if there's a way for us to crosswalk COVID data against our youth and care data to be able to be more explanatory in a response going forward.
I just can't thank you enough for looking at this, because I think this will go a long way towards, we tend to look at the back end of after the child has suffered all this trauma, and then we say, oh gee, what are we going to do, because this child is misbehaving now. And if we could get it, when they're going through the trauma instead, I think that we would have a lot more functional adolescents who have been traumatized.
I agree with you, Representative, and I often use the phrase, stop focusing our attention on what a child does and ask what happened to them.
That's perfect. Thank you for that. That's great. Thank you.
Thank you, Representative. So that concludes the questions that we had for DCF. Do any of my colleagues have any follow-up questions at this point? Representative Walker, there was a lot of information given about the trafficking. I'm not sure if you had the opportunity. I know you're on multiple Zooms, so I apologize, but I don't know if you had any follow-up questions about that at this point.
I did not hear and I didn't read it, so what I can do is I can call the commissioner, so I don't have to make people have to go through this again. But the one I did want to find out very quickly besides that one was the the differential response system. So I saw that it was not reduced. I mean, it wasn't eliminated, but that it still is in existence. But can you just explain to me briefly what is it that you're doing in difference than what you were doing with differential response system?
The practice has not changed at all. The explanation that was provided had to do with where it's listed in our line items, but the practice has not changed.
Oh, okay. So
Representative Walker, I know you'll be interested in this.
I'm sorry.
I'm sorry.
So I just want you to be aware that the explanation is there. I red flagged that my concern is that they're merging line items And we always like to see where all the dollars are flowing. I understand that it has to do with the Family First funding, but I just wanted them to be aware that anytime we merge lines, I'll speak for myself as a policymaker, it makes me very uncomfortable. So, but they did explain that they're not moving away from it. It's just where the payment system will be in the budget, which personally I just think makes it harder for us to track. But that's just another whole conversation.
So I want to echo what my colleague said, because it makes it, I mean, quite honestly, what I have to do is I have to take last year's budget and get the line items from last year's budget to go to this one, which, you know, for whatever reasons, I understand, but maybe it would be helpful if when we create the SID for that, it has reference to those other lines so that we know where the money is coming from. It would make it easier for us. And I'm sure you want to make it easier for us.
We sure do. Melanie, can you elaborate any further just in terms of the flexibility that was needed between SIDS that prompted us to do this? Because we certainly were not doing it just for the sake of confusion, certainly not.
Yes, thank you. And actually, Rep. Abercrombie, what we're doing here, what we're asking to do here actually gets to what your concern is. Right now, our DRS account funds our FAR contracts and our IFCS program. The creation of this new community care coordination account.
What's IFCS, please?
Integrated Family Care and Support. If you recall, those were the cases that were unsubstantiated but still on DCF's caseload. And we brought forth the ability to do some care coordination outside of our doors. And so the reduction in those cases being, you know, unsubstantiated, low risk, being served in the community is Integrated Family Care and Support, IFCS.
Which is basically what differential response was in some regards, because it's going into houses without the expectation of putting them on the books.
So a little different, because the FAR case, those cases that go down the family assessment response don't get a disposition of substantiated or unsubstantiated. These are cases that were investigated, yet we still saw the need for a need. So it was the other end of the investigative process that if it was unsubstantiated and low risk, but we still, so think maybe a teenage mom that got referred to us and we didn't find any abuse or neglect. That might be a case that we could refer to a community partner to help shore up their parenting capacity under IFCS. That's probably a quick example of a case that would help go that route.
Okay. I think I understand. And in order for us to get Family First funding, they have to all be in one specific line item. Is that what I'm hearing?
Under the CME, Mel, can you answer that?
Yes. So with Families First, the IFCS track, the voluntary care management track, those are that is what is defined as, if you look in our prevention plan, our community pathway.
Right.
So establishing one account for, they will all essentially, those two pots that we have now, plus the CME piece, that becomes one program now.
Okay.
So we are very much leaving DRS as an account line, and we are leaving our community pathway population as line item.
Okay. So Ken, you were going to send us the categories that are covered under First Families, Families First. Did you by chance do that?
They are in the documents that you were just sent a short while ago. I will carve them out for you and send you a separate email just so they're very clear.
Okay. Because I mean, I think I understand what you guys are doing, and I can understand that, but what I just want to make sure is that we still provide the services. So that was
yeah.
Thank you, Madam Chair.
You're welcome, Representative Walker. Ken, anything that you're sending, please send to Madam Administrator Keene. This way she can send it out to everyone. It makes the flow easier for us.
Yes, please. Thank you.
Any further questions or comments?
No.
Seeing none, this concludes the subcommittee for our meeting with DCF. I want to take this opportunity to thank you, Commissioner, and your staff, and congratulations again on the WAN-F and the approval of the Family First program. So congratulations to everybody. Thank you for being here. I think Representative Walker's trying to get in there. Go ahead, Tone.
So the other thing is that what you're going to have to do for the WAN-F settlement, that was another item that we were looking for. Nothing?
We don't have there's not a WAN-F settlement. There is the court monitor's report of achieving our outcome measures. There's not a settlement. It's an exit strategy plan. So there's not a settlement. It's an exit.
Exit, so we don't have to carve out anything or do anything. Awesome. Okay.
That's why I was saying congratulations, Tony.
We're not quite there yet, but we're not quite there yet. We have very favorable report from our court monitor. So we're not quite there yet, but we're very excited.
I got faith in you guys. I got faith. Thank you. Thank you very much, Madam Chair.
You're welcome. Madam Administrator.
I think we're all set, Madam Chair.
All right. Well, thank you everyone for being here today. If we feel that we need any further information, we will definitely reach out to you, but being that it's a short session and we need to get this budget done, I think we're probably in a good place. But I want to thank you, Commissioner, and your team. It's always a pleasure, and everybody have a great day. Get out in that snow